And I want the viewers know that you're not just an expert on ALIF. You said you have been practicing for 15 years, and you talked about some others. I'm sure you see my screen that I'm sharing right now.
I do.
And so, explain the surgeries that in this list that you perform, and I will point to that for the viewers. Please go ahead.
Oh my gosh. Okay. So I do all of these at some point or another. And the beauty of having all the arrows in your quiver is I know which arrow to use on each individual target.
Yes.
So the way you have your slide laid out here, the 12 o'clock position PLIF, that's more or less the great grandfather, I guess you would say, of fusion. We were just doing screws back in the 80s, and that didn't heal very well. And it gave us none of the benefit that you're describing, which is to push the bones further apart, make more room. Mm-hmm. We were just trying to make things stiff. But the interbody concept from mostly Harms, but a few others, allowed that reconstruction. The problem with the PLIF is we got to move the nerves. We got to come in straight from the posterior aspect or the back of the spine. And there's a lot of squishy things in the way there that don't respond very well to being moved around. And so then the idea of let's attack this spine from a different angle, and what limitations will we run into with each level of the spine? So L1, 2, L2, 3, et cetera, based on the local anatomy. The way I think about it, the perfect surgery is coming in from the front. We do that in the neck all the time. Mm-hmm. Right. It's ACDF is probably one of the top 5 most successful surgeries performed on humans. And the reason we do that is it's easy to get there from the front. We can get there almost as easily from the back, but then we dissect all the muscles out. The patients are miserable for 3 months. Mm-hmm. And so if we can come in from an angle where we don't have to cut as much soft tissue, less damage, but yet get the same restoration, then let's stop going in posteriorly. Let's look at angles, either TLIF, as you have there, or transforaminal lumbar interbody fusion, which is a little bit of an offset approach, but still posteriorly. And then as you go around the clock, OLIF is an intermediate between the transforaminal and the DLIF or XLIF or LLIF or whatever trademark term you want to use there. Which is coming in directly from the lateral through the psoas muscle. There's now also an anterior to the psoas approach, which is down in your, that's the psoas muscle you're just showing. So anterior to that, so we do a little bit less dissection. It's a little bit trickier to get the reconstruction. So it hasn't had as much commercial success as I think Medtronic wanted. But then there's a workhorse of ALIF, which is a great surgery, phenomenal outcomes, but has some significant anatomic limitations and risks associated with it.
And I want to emphasize there that I as well has performed all these surgeries. As a matter of fact, in 2012, my workhorse for many of my patients was ALIF. And yep. I tell to many of the people who are involved in that, if I wouldn't have moved from my first place to my current place, I would not have been getting on board with the OLLIF, because ALIF worked so well with me because I had a surgeon who would give me access in 15, 20 minutes.
Yep.
ALIF, you have a general surgeon or a vascular surgeon that open up your belly, is familiar with the anatomy, and there are major vessels there. Now, I am not exaggerating to say that in 2022, and will be the same in 2023, people still die of this surgery.
Yep,
it's not done properly.
I think of ALIF as juggling chainsaws.
Yes.
When it goes well, everybody thinks, "Ooh, wow, that was cool," and when it goes badly, it's ugly.
Yeah, it is ugly because when I moved in 2012 to a new place, the surgeon who was helping me needed 3.5 hours to give me access for.
Yeah, impossible.
And that is no different in some places in University of Minnesota and big places here. That has not changed in the last 10 years. So if you have a good team, this is a beautiful surgery. I love it. But if you don't have a right team, because there are so many smaller vessels in funny locations, especially vessels that go in the bad area behind the well, behind the veins and so on, and that can turn ugly in this town, somebody has to be transferred from a surgery center to the hospital with the surgeon hands in patient's belly.
Belly, yep.
And that makes this surgery a hit and miss. But it's a beautiful surgery when
Yeah, I think your point is spot on. If you've got the right infrastructure and you've got a vascular or general or trauma surgeon who understands what you need and only what you need, and they're efficient with their hands, it can be slick.
Yeah.
I had to, when I moved here to Athens, I had to get that system in place, and it was amazing to me how differently they look at anatomy than we do. And the idea of control and exposure. Fred Simeone used to say, compared to one of the other neurosurgeons there who wanted to see everything and get control everything. And Dr. Simeone just passed away, sadly, but he was a great man. His comment was, I know there's a tiger in that bush. Why would I stick my finger in that bush? And so
the tiger is there. The tiger
yeah, right.
waiting.
So I don't need to go find it. I know where it is. Leave it alone, right? And I don't. To your point, a lot of the vascular surgeons they want to go find all the tigers, and we don't need to see them. All I need to see is L5S1.
Yeah. So